A very good morning, everybody. Um, I'm presenting the, this is a small study we did in Nepal, Lumini Institute. It is intraocular lens implantation with decreased calculated IOL power for emmetropia and post-operative refractive status at age of 8 years in congenital and developmental cataract. I have no financial companies to disclose. As we know, congenital cataract is one of the most common cause of treatable childhood blindness, accompanying 5 to 20%. And surgery for congenital visually significant cataract must be performed as early as possible to prevent irreversible amblyopia. Optical correction includes aphakic glasses, contact lenses, and primary intraocular lens implantation, each with advantages and disadvantages. Primary IOL implantation in pediatric cataract has been choice of surgical procedure nowadays. However, the age at which IOL needs to be implanted is still debatable when it comes to infants and toddlers. In Nepal, in 2015, we have pediatric cataract workshop, and it recommended IOL implantation after 6 months of age, but below 6 months, as the adverse events are high, is not recommended. And initial undercorrection of IOL power is common practice in children undergoing pediatric cataract surgery. So alternative is to implant full power and then IOL exchange at the later dates. However, if primary IOL with undercorrection is done, long-term refractive status of these children is largely unknown. Moreover, there are many studies suggesting different diopter deduction for calculated biometric power. We can see with the different studies done by Pleasure et al., Crouch et al., and Wilson et al. Recommended for less than 1 year deduction of 6 diopter and 4.6 for 2 to 3 years. Even up to 15 to 18 years, there has been suggestion for 0.38 diopter deduction. Again, there are recommended studies from different studies like Crouch et al. For 1 year 4 diopter deduction, for 2 3.5, 3 to 4 years 2.5. It goes like this, and emmetropia for 9 years. Dahan has given the deduction of 20% in first year of life, and 2 to 8 years 10% deduction. Again, ID et al. Recommended this rule of 7, where each like for 1 year we deduct 6 plus makes 1 makes 7. So at the age of 7, plano is implanted, and for 8 year minus 1, it goes like that. So our study's objective was to evaluate refractive changes after IOL implantation and what is the exact scenario at 8 years of age. So we did retrospective study in between 2013 to 2015, 3 years, and data were collected regarding demography, axial length, biometry, post-operative refractive status, and the main outcome measure was post-operative refraction at 8 years. So inclusion criteria was less than 8 years congenital and developmental cataract and primary IOL implantation. Traumatic, complicated, syndromic cases were excluded. So coming to results, there were 181 children with 288 eyes, 40% being unilateral and 59% being bilateral. Male were 67%, female 32.3% with ratio of 2.09 to 1. Right eye and left eye is nearly equal. So emmetropia was achieved in 20 out of 77, that was 25.97%, whereas myopia was in 28% and hypometropia in 45.45%. This is our result, which showed axial length was 20.75 at the age of 1, and similarly it is increasing, and by this 6 years 22.47, and biometry at the age of 1 year mean was 28 around, and by 5 to 6 year it comes to 22, 23. So our aim of hyperopic correction was 3.5 at one age and deducting 0 0.5 in each age, and by 8 years we prescribed implanted plano, but the mean hyperopic correction in our study we found that is more or less similar to our target. Now coming to the discussion part, congenital and developmental cataract commonly bilateral as in our study, and there was no preference for laterality of eyes. Male children were found twice as common than in female. Targeted emmetropia was achieved in 26%, hyperopia persisted in 45%, and myopia in remaining children as in the study by Sachdev et al. The mean axial length at 1 year was 20.75 millimeter, and at 7 years, up to 7 years it is increasing and suggesting that anatomical maturation was not completed yet. Mean refractive power at 1 year of age was 20 diopter, which went on decreasing. At the age of 6 to 7 years it was 22 to 23. So it suggested that myopic shift was continuing as the age increasing. At early age was more shift in myopic than in later age. It was similar to the study by NID et al. And Coker et al. So coming to the conclusion part, primary IOL implantation with hyperopic correction is accepted practice. Emmetropia can be achieved, however some hyperopic or myopic refractive status at 8 years of old is not a surprise. Myopic shift continues as the age increases, and at early age more shift in myopia than in later ages. And counseling to patient regarding need of follow-up is very important, because we lost about 2/3 of patient up to 8 years of follow-up as per record.